Okay, thank you.
Thank you.
Okay, so pain is, as most of you maybe know, an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Oh gosh, so my computer is, okay. But the most important thing of this definition is that pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors. Pain and nociception are different phenomena. Pain cannot be inferred solely from activity in sensory neurons. Through their life experiences, individuals learn the concept of pain. A person's report of an experience as pain should be respected. Although pain usually serves an adaptive role, it may have adverse effects on function and social and psychological well-being. And verbal description is only one of several behaviors to express pain, and the inability to communicate does not negate the possibility that a human or not a non-human animal experiences pain. What I'm trying to tell you is that, as we will see later, is that pain is real in every single individual, no matter what is provoking that pain. People are suffering from pain. Okay, so some individuals present an inadequate control of their acute pain, developing chronic pain and symptoms associated to this pain. So the pain you are feeling will depend on intensity, severity, sensibility, and emotions. We'll see later. And pain is a complex and subjective experience. This is a very important point because we are trying to explain many times pain from a single point of view, and pain is real complex. It's very difficult to explain complex from a biomechanical point of view, from a psycho point of view, even from a social point of view. What I'm trying to tell all of you is that please think about that pain is complex, it's multifactorial, it's not only one factor behind this behavior, this feeling. So please consider a lot of factors that I'm trying to show you later. So 1 out of 10 adults develops chronic pain, which is really, really, really important. And the way people process chronic musculoskeletal pain depends on many factors like sensorial, emotional, cognitive, behavioral, or even social. And these factors may contribute in the transition between acute to chronic pain and its perpetuation. So you have to consider a lot of dimensions of pain. Traditionally, maybe we studied in the past, there is a model, the biopsychosocial model, that tells you that you have to consider not only the tissue, but also psychological aspects or social aspects. But you have to believe in that because, for instance, considering the information I'm going to provide right now. Chronic pain specifically has been recognized as pain that persists past normal healing time and hence lacks the acute warning function of physiological nociception. This is a very old definition by John Bonica, but it's very important. Even right now, we are trying to define, or we are trying to name chronic pain as persistent pain, because chronic pain has some kind of negative feeling with patients. So I prefer to use with my patients, or even in research, persistent pain instead of chronic pain. And this pain, it lasts or recurs for more than 3 to 6 months. So as I mentioned before, the biopsychosocial model is very well known, I can imagine, for most of you. There is one dimension related with biological issues, another one related with psychological dimension, and finally with sociological dimension. Let's try to define all of them, starting with the biological. Maybe you are more familiar with this dimension of the model. I would like to show you that the concept of nociception is not equal as the concept pain. So when we receive a mechanical input or a chemical input or even a thermal input, you know that one nerve, neuron number 1, is matching with neuron number 2 in the spinal cord, and this information comes and moves up to the brain. Okay, so this would be the nociception concept, but nociception doesn't have to provoke pain. What provokes pain is the interpretation that your brain is doing in the central system, and it depends on your previous beliefs, your emotions, and your previous experiences. So it depends on all these 3 factors. You will develop pain or not. So the first key message is not all the nociception provokes pain in one human. So I strongly recommend the reading of this book. This is The Pain Revolution. I think 10 years ago, something like that, the physiotherapy community is suffering a full revolution thanks to people, brainy guys like Lorimer Mosley and David Bartlett from Australia. They wrote a superb book like Explain Pain. It's titled Explain Pain Supercharged, which I strongly recommend this book. They used to say, first of all, that pain is always real, no matter what is causing. So you have to have empathy with your patient. Sometimes you feel like, oh, what are you talking about? Your pain is like a something psychological, so it's not real. No, you have to, I think, my humble opinion, you have to consider that pain is always real. This is the first point. The second one is pain relies on context and cues. That means that, for instance, this experiment carried out by the team of Lorimer Mosley in Australia, they projected 2 lights in one hand in different patients, in healthy patients, 1 blue light and 1 red light. And they asked the patients, hey, how do you feel in a vast scale between 0 and 10 in terms of pain? And what was surprisingly, they reported that they felt 8 out of 10 when they received the red light, and 6 out of 10 when they received the blue light. But I have to tell you that the red light didn't add any component talking about temperature. It wasn't a hot light. Can you imagine that pain depends on the context? Because patients were expecting to suffer pain in this experiment, but actually the laser didn't do anything or did nothing. So it was surprisingly. So keep in mind that pain relies on context for most of the times. Pain is all about protection. Yeah, for instance, can you see a violinist? The fingers on their left hand are more sensitive than fingers on the right hand. And this is not because they are using the right hand a lot of times per day, they suffer for tendinopathies or whatever. This is because their brains created a protect system to this part of their bodies. Additionally, for instance, in the other picture, it's a very funny picture. That can you imagine a guy coming from Spain, for instance, under the umbrella, and another one coming from Norway. The guy coming from Norway maybe having sun. He will try to make the most of having sun because his pain protect system is not activated. But maybe the Spanish one is activated because the Spanish guy maybe doesn't need too much sun. So pain is all about protection. So pain is a good system, but when pain lasts more than expected, it will become a problem. The fourth point is very, very interesting. So pain and tissue state are poorly related. There are a bunch of information right now that tells you that there is not a strong correlation between chronic pain and the tissue state. For instance, sorry about the picture, there is not a high quality picture, but can you see that, for instance, in people with no low back pain, in asymptomatic patients, if you are in the age between 40 and 50, maybe half of you will show a disc height loss. Okay, so you've got something very special in your low back when you are being explored by MRI, but you don't have any symptoms. So there is not a big correlation between the tissue and the pain the patients are reporting. So there are a bunch of information I told you before. For instance, we carry out a lot of studies about the association between structural changes and symptoms in chronic shoulder pain, and we found no changes in populations with shoulder pain and without shoulder pain in terms of tendon thickness. There is a beautiful study carried out by Tasha Stanton in Australia. They found that conscious experience of feeling stiff does not reflect true biomechanical back stiffness. You know that many people tells you that, hey, I have low back pain and I feel a stiffness in my back. And what this team did was trying to compare the feeling of stiffness with the feeling of pain. And they did not find any correlation. So it's not that when you are suffering low back pain, you've got a real stiffness. You've got a real stiffness, but your stiffness is in your brain. It's not in your low back. All your vertebrae are moving correctly. They are not fixed each other. Okay, so stiffness, the feeling of stiffness is in your brain. Another beautiful study, for instance, for Deborah Falla and her team in Germany a few years ago, they found that with shear wave electrography revealed that similar muscle stiffness in people with and without chronic pain, despite the sensation of increased neck stiffness in those with chronic neck pain. So people with stiffness in neck pain and without neck pain, they didn't find anything using ultrasonography. They didn't find anything special, any difference between one group and another. And you know perfectly, to finish this part, that the stretching interventions, for instance, don't change either the muscle or the tendon properties. It seems to mostly occur at a sensory level. So you've got a lot of information that why don't we move sometimes from tissue to brain to see what is happening in the brain, not only in the tissue, but only in the brain, because tissue cannot only explain the pain people feels in 100%. Okay, one of the last studies, for instance, is that very curious study that they analyzed a group of people during 30 year follow-up, and they found with low back pain that in young people with low back pain, early degeneration in lumbar disc predicts progressive degenerative changes, but not pain. So it doesn't matter if you are a young guy and you've got degenerative changes in your back. During 30 years, after 30 years, you maybe will have more degenerative changes, but it doesn't mean that you are going to suffer pain, which is very important, because we used to say people, hey, be careful because you've got some problem in your lumbar discs or whatever with 20 years old, and maybe your back will be hurt in the upcoming years. This is not true. So please trying to avoid these kind of messages because it's not supported by evidence. Another good point is we are amazingly adaptable, bioplastic, and learners. And this is because neuroplasticity. Neuroplasticity refers to the brain's ability to change its structure and function. It's not an occasional state of the brain, but rather the normal ongoing state of the human brain throughout the lifespan. And more important even, that plastic changes in the human brain lead to brain reorganization that might be demonstrable at the level of behavior, anatomy, and function, and down to the cellular and even molecular levels. What I'm trying to tell you is that brain changes very quick to the dark zone, but also to the bright zone. So think about what you are doing in your practice, clinical practice every day, can influence neuroplasticity in the central system. So these changes, as I mentioned before, are very important, especially in people with chronic pain. Okay, so movement is king. So people with chronic pain, we have to try to make people as active as we can is the key. Okay, and finally, understanding and retraining your pain system works. Okay, it's not a very quick question. Okay, it takes too long. Okay, can you see? Sorry about the quality of the picture, but you can see that in a program with people with chronic pain, one treatment was focused on the tissue and drug approach, and the other one was focused on understanding and retraining your pain system. The level of pain, the VAS scale pain, decreased in the group understanding and retraining the pain system at 1 year follow-up, with a very big difference. But it was a 1 year follow-up. It wasn't in the first month. So consider when you are treating people with chronic pain that it takes time. It takes too long. Sorry about it. Another question that is capturing my mind right now and the physiotherapy community is the concept of overdiagnosis and overtreatment in musculoskeletal disorders. Too much medicine has led to overtreatment, overutilization, interventional over-medicalization, and low-value care. So consider, for instance, in people with non-specific low back pain, and they don't have any red flags, they are not presenting any red flag, please avoid magnetic resonance imaging, avoid MRI, because they are not giving more extra information and it's high cost. Additionally, for instance, most posture abnormalities are likely to be variations of normal and don't differentiate between people with and without pain. So posture is not related with pain. So there is not the best posture ever talking about pain. You can be like lordotic, you can have kyphosis or whatever, and it doesn't relate it with your pain. So please don't be very focused on correct posture in your patients when you are trying to treat pain, not when you are trying to work out your patients. I'm not talking about it. I'm talking about pain, okay? And findings suggest that many changes labeled as abnormalities are normal and may not be associated with pain or symptoms. For instance, we created in the past a lot of diagnoses like lumbar disc protrusions, labral tears in young people without hip pain. So please consider that most of them talking about chronic pain doesn't have a strong correlation. So to sum up this part, there is no magic cure for many persistent and disabling musculoskeletal pain conditions. Self-management is the key, and to reduce stress and burnout experienced by many clinicians who are unable to deliver on such substantiated promises. Okay, have you ever thought why your techniques work? I did in the past and even right now. So can you consider placebo effect? So it's very important because when you apply any single technique in podiatry, physiotherapy, medicine, or whatever, you have to consider whether your effects are mediated by a placebo effect. And this is not too bad, but you have to consider that maybe what is important for this patient is the placebo effect. For instance, when you are applying a very painful technique, you have to consider that maybe the effect can be mediated by the pain inhibiting pain, the NICS mechanism. So just try to think about. It's not only things that are happening in the tissue, but also things that are happening in your brain. Or the impact of expectations on analgesic treatment. I don't want to bore you too long, but can you see this experiment that in the baseline, people are suffering between 6 and 7 in the VAS scale. And when you apply an opioid drug, if you don't have any expectation that this intervention will be worked, your improve is going to be very, very mild, even not very appreciable. But if you are expecting a positive, something positive, having an opioid drug, can you see the difference between this group and this group is tremendous. It's a tremendous difference if you are expecting something positive. So please try to play with the patient expectations, trying to create a positive atmosphere in your clinical practice. I'm not talking about that you are going to tell lies in your clinical practice. I'm trying to motivate your clinical practice in the sense that maybe sometimes what it works in your clinical practice, it depends on, first of all, the expectations the patients have. Okay, another funny thing is the nocebo effects. Do you unconsciously use them? Did you consider your language before these presentations? For instance, when you are treating one patient, are you talking about, hey, you've got a disc degeneration, you are very bad because your disc is really, really bad, but don't worry about it, I'm gonna save your life. Okay, why don't you consider to use instead of things like, hey, this is an indicator of aging, so don't worry about it because this is because you are alive. So there is plenty of information telling you that language matters. So be careful with the language you are using with your patients. Another good point, sorry if I am in a hurry, but another good point is the natural course of a disease. Consider that every single tissue has its own natural tissue healing. And sometimes you are applying a lot of techniques and your patient gets better and you think, oh, I'm God, okay? And maybe it could be, of course, but you have to consider that maybe it's because the natural tissue healing times is like this. So if you do nothing, maybe it's going to be healed too. Okay. There is plenty of information behind. So natural course of a disease is a very important point. For instance, low back pain gets better in a frame time of 6 weeks. Okay, so maybe you are treating your patient and you get some good results and you say, okay, this is because my therapy. Sometimes you have to think that this is because this is the natural cause of a disease. And pain comes up and down for many chronic musculoskeletal conditions. So consider that maybe sometimes when your patient tells you that I'm feeling great, this is because he's in a down part of their process. Consider that, please. Very brief, I'm not sure I'm in time, I think. So the second dimension is the psychological dimension. Okay, recently we published an umbrella review about which psychological factors are involved in the onset and on the persistence of musculoskeletal pain. And what we found is that there is a bunch of psychological concepts or factors that influence how people feel their chronic pain. For instance, additionally, we published a lot of papers about pain-related fear. This is one of the factors. Pain catastrophizing. Maybe the most well-known concepts are kinesiophobia or self-efficacy. There are factors that you have to consider that because sometimes or many times the big problem or the main problem of your patient is something related with how they are coping with these kind of cognitions and emotions. Maybe the biggest problem is that this patient feels very scared about walking or about running. Maybe he or she is feeling kinesiophobia. This is the real problem. The problem is not that some structure is failing or not. This is the consequence. Maybe the big problem is one psychological factor. And they are very easy to address with some simple techniques using the de-education and the great exposure to kinesiophobia or self-efficacy, or trying to improve self-efficacy. They are very easy to manage, but they are important to be considered. And at that point, you have to consider that which came first. An ankle sprain developed kinesiophobia, or a guy with kinesiophobia develops an ankle sprain. So you have to analyze and you have to consider. In the first case, maybe it's not very important kinesiophobia because you've got an ankle sprain and it's more than natural that you feel kinesiophobia afterwards. But if you are a guy with kinesiophobia in your life, in the way you move, and you suffer an ankle sprain, you have to consider not only treating your ankle sprain, but also treating kinesiophobia. Finally, the final dimension or structure in this biopsychosocial model is the sociological dimension. And it's very important because most of the times we forget that all pain is real, and it always involves many factors associated with the person, and this is the very important part, interactions with their environment. Some patients used to tell you, hey, I don't feel pain in your clinic, I don't feel pain at home, but I feel pain in my job because maybe I feel stress or whatever. And we have to consider that, because why don't they feel pain in your clinic, in your provocative tests, and they feel pain in their jobs? So you have to consider, and we are not psychologists, but we have to make the most of considering these factors and try to improve the health in this kind of patients. Finally, I think I'm in time. I would like to present a beautiful summit that we created in the recently, the Physio Summit, that will be launched on the 1st of October, Physiotherapy Summit. I'm presenting you because this is going to be a very important summit in which 16 speakers across the world are going to discuss about the present, but also the future of the musculoskeletal disorders across the world. Talking about artificial intelligence, virtual reality and pain, passive techniques, active techniques, things that maybe can be of interest for the podiatry community. You are more than welcome to attend this summit. To finish, we used to say healthy brain means no pain, and don't look at your pain, look at your brain. Thanks a lot. Thanks indeed for the invitation. I'm very happy to answer all the questions. Yeah, thank you very much.